So welcome everybody. My name is Mo Bhandari. I'm the editor-in-chief of Ortho Evidence, and we have another, I hope you'll find this to be an interesting discussion with an expert in the area of guideline development as well. Certainly has lots of ideas and has written quite a bit in the area that we'll be speaking. But before I get to the introduction, just reminding everybody that this is one of our new webinar series, and we'll focus this evening will be on injectable therapies for KneeOA, talking a little bit and focusing right now on the American Academy guidelines. But as you'll see, we may in fact dive into other areas as well. Just from the point of process, and as we get going, I'll ask you to stay muted, and maybe I'll go to that slide first, and I'll come back to the introduction. But we are recording this event. If you want to speak, we'll have some time at the end for questions. You can certainly turn your video on and ask questions directly, or you can use the chat function throughout. I suspect everyone's pretty comfortable with that approach. So I wouldn't, you can use that throughout the presentation. And as we see questions pop up, we'll make sure that we try to do our best to address them. There's a host of ways you can ask questions. And again, we'll be making sure that the full recording is uploaded and available at the Ortho Evidence website after the event. So let me get back, if I can, just to introduce Dr. Bhandari, who is currently the director of the Center for Treatment Comparison and Integrative Analysis. He's an assistant professor of medicine at Tufts University School of Medicine. Really an accomplished scientist, certainly someone who has done a lot of thinking in this area. And I just want to take a moment, Ravi, to welcome you this evening and welcome you to this conversation we're about to have. I've got some slides, Ravi, that we'll kind of walk through, but really they're more just guides for us to be chatting throughout the way. If anyone else has questions or comments, please do continue with that as we move forward. But really the challenge I think we're facing has been this fall and rise, and I'll talk about the fall really related to guidelines. Guidelines are powerful tools, and there's a host of guidelines on KneeOA. I suspect many of you who are listening have probably have read various degrees and maybe read a host of, but there's many double-digit numbers. And I guess before I get started, Ravi, I wonder if you could speak to us. I know you were one of the leaders in the ORSI guideline development. Can you speak to a little bit about why guidelines differ and ultimately what you believe in your experience are the elements of a good quality guideline?
Oh, thanks for the stellar introduction, Mo. So it's my pleasure joining you and this forum. So yeah, I mean, you're right. I mean, on the same topic, we have like for osteoarthritis in this example, like we have like multiple guidelines, and almost all of them kind of differ on several key issues or key recommendations, I would say.
Yeah.
And one of the kind of the key issue would be definitely intra-articular treatments is one, and then some other nutraceuticals and other things.
Yeah.
So one other thing, like, I mean, I worked with the Osteoarthritis Research Society International Guidelines. I'm the primary author on that one. I also worked with the AOS not the AOS, RC Guidelines, previous one, 2014. And also, like, I mean, probably like most of you may not know, actually, I was the evidence lead for even the Royal Australian College of General Practitioners guidelines for osteoarthritis. And I'll share a little insight there. So we kind of had pretty much similar evidence base for both these guidelines because I was the one who developed it around the same time.
Yeah.
So for the RC 2019 guidelines and the RACGP 2018, late 2018 or 2019 guideline, so we had the same thing. And they both came out with slightly different recommendations, especially for the intra-articular therapies.
And that's the point I think we're making, right? Is that we're like, you have groups of individuals looking at the exact same data, coming up with very different results. So can you help us understand that?
So, I mean, again, at the end of the day, we call this consensus practice guidelines. So there is a voting panel. So like even this panel of members, which could depend anywhere between, let's say, like an hour number, somewhere between 10 and 15, that's the usual composition of the guideline. And it all depends on how they see the guideline, how they pursue the treatment option, and how, I mean, their, let's say, clinical experience, that's the consensus part. I mean, the expert part, their own expert. That's what is shaping the final guideline. So it's like, okay, everybody gets a single vote. So depending on the composition of the panel, whichever way these 10 or 12 people are thinking about, that's how the recommendation is moving. You give them the same exact evidence.
Yeah, I mean, and I guess it gets to the point of that, humans are going to make decisions based on, their own intrinsic beliefs, and the makeup of a guideline committee is really important. I mean, in many
Yes.
ways, you've led several of these committees, but so the challenge, I think, for injectables, or sort of the opportunity, has always been, well, there's this treatment gap, right? Patients in need of treatment, but they're a little bit early. They're not quite a candidate for the more definitive surgical procedures like the total knee. So that, becomes an area, well, how do we maximize non-operative? We're focusing on injectables, but for some of those who are listening, I'm sure there's a host of things we're doing. There's a host of non-operative treatments, and we talk a little bit about that. What made things even more, I guess you could go, going from a real difficulty to almost a crisis, was the last few years, where we've had a real difficulty in getting people back to normal with respect to surgery. In fact, during that short period of time in 2020, during the time of the pandemic, where it was claimed the pandemic around March 11th of 2020, they suggested that there were about 28 million cases that were canceled or postponed, and that led to major challenges. And in fact, when they looked at specifically, the highest cancellation rates were occurring in orthopedics. So we were seeing orthopedic hip and knee surgery, Ravi, being called lifestyle surgery, and therefore it was lower priority, and therefore there led to a huge potential backlog. Now, there's been all kinds of efforts to really deal with the backlog in Canada, certainly in the US and other countries. But this issue and these kind of papers have been coming out. I talked about this yesterday when we were discussing this with Aaron Johnson, discussing sort of the whole patient pathway for managing KneeOA. But the idea of waiting for surgery and the pain and the quality of life is quite critical. And so, some patients, in fact, and not an insignificant number of them, consider that period of time of waiting, a condition of worse than death. And that gets to this whole issue of what do we do? Well, here are some of the common injectables, you're aware, and we talk about, or some combination. And this is where I'd like to spend the next, 15 minutes or so discussing and getting some insight from you on as we go through this project. This was the paper. I'm sure you're well aware of it. I know you would have been reading all of this content as we were going through. But back in 2012, paper in the Annals of Internal Medicine comes out. It's a reputable journal. It's a reputable group of authors. They've done a systematic review some years ago, as you can imagine. And this is the conclusion right then and there in 2012. So I'm curious, when you read this conclusion, as an expert, having someone who had done quite a bit of work in this area, had been thought deeply about this area, what did you think about this particular conclusion? I guess I have my own questions about it, but when they said that we conclude that the benefit of viscosupplementation, this particular case HA, on patients and function, and on pain and in function in patients with symptomatic OA of the knee, is minimal or non-existent. And that was, the actual concluding statement. I wonder, when you read that, what was your initial reaction?
So, I mean, like, yeah, as you said, that was kind of shocking to me. And also, like, what I felt was like, okay, this is pretty far away from the real truth or the real benefit the patients are experiencing in our clinics. And to that aspect, that's which kind of led to like my own network meta-analysis, which got published in 2015.
And I'm going to get to that.
Yeah. The key thing to that is, this one, they were looking at, okay, viscosupplementation compared against intraarticular placebo. And that's a huge placebo effect, which for any treatment, like any intraarticular treatment, to kind of overcome and then have a superior benefit on top of that. That was the major hurdle. Most of these intraarticular treatments are unable to kind of climb.
Right. So a really important point is, when we look at the context of placebo-controlled trials, the idea that placebo is nothing is fallacy. I mean, and I think your 2015 paper, which we'll talk about shortly, came to help us understand that. the reality is that placebos are active in many ways treatments, and and we'll get into just how active they are when we discuss your paper shortly. But this is what happened, right? So in 2013, the year after, American Academy comes out with their document, and basically at that point they say in their ninth recommendation, we cannot recommend using hyaluronic acid for patients with symptomatic osteoarthritis of the knee. They had a fairly strong recommendation. They'd use that, they'd use their basis for why they called it a strong recommendation. Now, here was the issue. And when you looked at the actual data for any paper or any meta-analysis that's looked at this, nobody ever has argued that viscosupplementation, we use the word hyaluronic acid treatment, has a statistically significant improvement in pain. No one ever argues that. Like they say, when you look at it, there's still a statistically significant improvement. I think the debate really has flipped to this issue of minimal clinical important difference. And I wonder if you could speak a little bit to that, this issue of minimal clinical important difference, because what happens is that paper that sparked it, the American Academy then said, they didn't think there was it didn't go beyond the threshold of MCID. That became the new narrative. And I wonder if you can speak a little bit to that.
Yeah, I mean, MCID is yes, it's a very important concept, and definitely it's not just a statistically significant effect. The clinically important effect is what patient really feels, and that's what patient expects. And that's very important. But then this minimally clinically important difference, it is, I mean, as you can see, we wrote an editorial based on the MCIR, MCID. So, I mean, the concept of that is it's anchor based. So what are you basing your anchor on? So if you're trying to compare something to intraarticular placebo versus oral placebo, where if those two are not exactly the same, or if there is a differential placebo effect,
for sure,
then you're not comparing apples to apples. So your anchor or your control is different. Right. That's when your MCID is not easily valid. And also the major issue with the AOS is that the MCID, whatever the metric, which is I think 0.4 or 0.5, they chose.
Yes,
they got it from a kind of a totally physical rehab studies.
Yes.
And also as a lot of studies, I worked with Professor Angst, who he's one of the key persons in the space of MCID, developing MCID. I think that's one of his paper was also kind of taken as a reference. So there are two key authors or key researchers who work on this MCID concept. One is Dr. Angst and the other one is Dr. Tupac. So Dr. Angst, definitely, I worked with him later on. We all agree that, it's not just, it's basically what it is okay, how much the patient kind of feels and patient is happy about. So, patient expectations are different for each different treatment. So you cannot apply an MCID for physical rehabilitation, which consists of everything. They not only had just a rehab program, they had NSAIDs, they had all of the things, exercise and everything. It's a combo program, including that. So something like that, you kind of take that effect and try to apply for, it's not fair to apply to NSAIDs or even to injectables or any other treatment. So you have to have an MCID specific to each treatment because it differs.
Yeah, and I think it's challenging. At the end of the day, we're talking about this one particular guideline, but every guideline and every decision we make has so many important consequences that, and I always make the argument that no group or no guideline committee goes out to specifically, create more challenges for themselves, right? Everyone's trying to find a way to say, can we find clarity? Can we get signal to the noise? But it's interesting to get your perspective because you've been very, very clear in your own work about, how do we change a guideline that may in fact, looking at the same data, there could be a different perspective. This is interesting. So the American Academy came out with this not that long after. They said, well, we put our guideline now. We think, we don't recommend using hyaluronic acid. This is back in 2013. And then they said, the interesting thing is, the management of moderate to severe KneeOA doesn't align with AAOS guidelines. And in fact, they were saying that the most commonly divergent treatment was people were using intraarticular hyaluronic acid despite their guideline. And the interesting point is they did a survey afterwards, and their perception actually was that, oh, I guess people haven't read the guideline, rather than they've read the guideline, but they have a different belief, in their own interaction with patients that they're going to go and use it. This was fascinating to me because this was all happening around 2013, 14 when we were getting engaged and involved. And I've learned now that I think in many ways, and I'll explain this to those of you who are wondering what this actually means, but in many ways, the way the AAOS looked at the group, the overall group that is considered viscosupplementation, they're probably right in what they said. But the clinicians who continued to use it were absolutely not wrong. And this gets back to this subgroup analysis, for what we can take it. But this is taken exactly from that original 2012 paper, Ravi. And I know you probably have this, but just for some of the folks who are listening and who may not necessarily understand how this paper was constructed, but this is a meta-analysis. And remember, the overall effect suggested that there was no difference. It was a statistically significant but clinically unimportant difference, is how they called the HA period. So if you see my cursor, this blue zone is what they call the threshold for what they're calling a minimal clinically important difference. Now, in their own paper, in one of their subgroups, they actually showed situations in which there were elements in which the average effect and the 95% confidence interval was to the left of that minimal clinically important threshold, which would mean that it was both minimally clinically important and it also was statistically significant. So when you looked at that, to me, the very interesting point was it's really a perspective of how you look at it. If you look at overall, you could say, well, if you take all HAs, all molecular weights, all cross-linking, everything like that, put them together, you can argue you might have some noise in the system. Still means that there's a statistically significant benefit, but it's not as big as if you look at, let's say in this particular case, I think those of you listening in would probably say, well, the very high and the high molecular weight products seem to be much better. Cross-linking seemed to help. And then the effect seemed to be very strong early, but it did not diminish to zero. In fact, there was still a statistically significant benefit that went on beyond 6 months. Would that be your interpretation of this particular graph? Is there something else that you'd want people to hear or know about this particular subgroup? By the way, this was not published in the paper. You have to go digging up and pull out their supplementary documents to find this. So this was buried among all their other graphs and things. But this wasn't in the original paper. It was in their appendix.
Yeah, I mean, you kind of nailed it. I mean, like, as you can clearly see, I mean, there is definitely effect for high and very high molecular weight. And also, as you said, yes, up to 3 months, definitely there is a significant effect. And I mean, again, like more than 6 months, actually, there are like very few trials which were done. And I think if I am not wrong, some of the trials they were including here were like at least for the more than 6 months or more than 6 months, even though there are not that many trials at that point of time. They were including some trials which compared hyaluronic acid to physical rehabilitation.
Yeah.
So, I mean, again, like, yeah, physical rehabilitation or physical therapy versus hyaluronic acid, I don't think that's a fair comparison. Okay, whatever, the trial is good. But then here, what you're trying to do is hyaluronic acid versus placebo, and physical rehabilitation or physical therapy is not a placebo.
Absolutely right. And I think you're right. So if you look at all the comparators and you look at all the things, there's a lot of noise, right? And when you put everything together, the actual overall treatment effect shifts a little bit. And that shifted it towards more null. But when you actually start looking at very specific characteristics, you can open it up. So again, this wasn't necessarily we needed another big multi-million-dollar randomized trial. What we needed to do was knowledge translation. And this got to your paper. So walk us through what network meta-analysis is. And just for, again, those who are wondering about what we're talking about here, there are situations in which you have the same comparator. So you might have a trial of A versus C. In this case, could be a placebo, for example, and it could be B versus C, but no trial of A versus B. Using network meta-analysis and the statistical analyses that are ensued, we can now infer the effect of A and B. And if you look at this particular web taken directly from your paper, you were able not only to give us insights about corticosteroids, about hyaluronic acid, but also about oral and intraarticular placebo, which I thought was fascinating, which gets back to your original point that a placebo is not a benign effect. Maybe you could walk us through a little bit of this and just tell us in your own words kind of what all this means.
Yeah, I mean, as you can see, like we looked at about 100, close to 130 trials, and we had about 32,000 patients. And compared to, like, I mean, an oral placebo, NSAIDs had an effect of 0.38. And the same compared to like oral placebo, intraarticular steroids had an effect size of 0.6. And hyaluronic acid has 0.64, which is compared to oral placebo. And when you go back to that 2012 paper, they were comparing it to intraarticular placebo.
Right.
So their effect size was 0.345-ish kind of.
Yeah.
So, and yeah, even like we are not showing anything different when we compare intraarticular hyaluronic acid to intraarticular placebo. Even in our study, it was the same.
Yeah.
0.37.
Yeah, right. It's exactly the thing. I think the point you're making here, and I think the thing I remember from this really profoundly was that a intraarticular placebo, folks, you know, is in this case a saline injection had the same treatment effect as oral NSAIDs, or something similar to that effect. I mean,
yeah,
it was
I can give you that.
Yeah.
Yeah, I mean, actually, intraarticular placebo had an effect size of, I think it's almost 0.3.
Yeah, pretty close.
So yeah, it was like 1.5 times of your acetaminophen or Tylenol, paracetamol, whatever you call. So 1.5 times of that. So that's pretty, like, I mean, it's more than an active treatment. It's not just a placebo. It's an active comparison.
Right. And this gets back also to saying, okay, you know what, we had this information already. So on ortho evidence, we have a database of trials. And this is now some years ago. We're about 130 million data points now. But when we look back, and we just did a cumulative meta-analysis, basically what we did is we looked at every single study and kind of added, you know, what the treatment effect was for overall hyaluronic acid over time. And roughly we see this drop happening around 2013 overall. You know, there's some changes and, you know, there's new data coming in and we see some things pushing in. That's all hyaluronic acid. What if we had actually differentiated early on and looked at higher molecular weight? Well, the higher molecular weight seemed to be staying pretty stable. In terms of the messaging, and I think the messaging that you talk about in your 2015 paper was always known, I think, Ravi, right? The known was that if, you know, higher molecular weights do just perform better than the lower molecular weights. The lower molecular weights does not mean they have no effect. It means that their effect isn't beating a threshold of what we consider patient important differences or minimal clinically important differences. The higher molecular weights seem to be both statistically and clinically important. And I think that was a really interesting point. So when we looked actually at, you know, specific guidelines and you started looking at the 2021 updates, we started seeing now that in fact there had been a big change. And I'll walk you through what happened. So during that period of time, as you know, 2015, your papers are coming out and there's lots more papers. So if you look at just the number of guidelines that were out, you can see kind of the top being a strong recommendation in favor of HA versus a strong recommendation against. 2013 was this one particular American Academy, but over time, you kind of saw this happen, right? There was what would be perceived anyways, if you perceived that there was value to using HA in terms of the evidence, there was a bit of a crisis in terms of, okay, well, it's no longer being used. There's insurance agencies are looking at the guidelines and saying, well, we don't believe there's a benefit here. And then there's this period of recovery. And if you look at the majority that have been happening, like there's a lot of guidelines happened between 2014 and 2019. And the one fundamental thing I noted was people started moving away from the idea of just HA and started saying higher molecular weight HA. So the ones that are in this latter part are really focusing on the higher molecular weight. And I think that is how they were differentiating it. So the concept of saying, if we take all HA, then you're probably in the same boat as the American Academy saying, well, there's a lot of noise in the system. We're not sure. The effect may not be that big. There's an effect, may not be big enough. But as they move, the messaging became much more about higher molecular weight. And this is now the 2021 updated guideline. And here's what the American Academy writes. The 2013 edition of this guideline strongly recommended against the use of viscosupplementation. In contrast to this updated version, the 2021 version found that statistically significant improvements were associated with high molecular weight cross-linked hyaluronic acid. Bit of a shift, but again, they kept their fundamental statement, which is all hyaluronic acid, not necessarily, but there certainly may be now a role. So they've pivoted here. Thoughts on that from your perspective?
I mean, yeah, if they are finding significant improvements, why were they still recommending against? So it could have been an inconsistent recommendation. So again, recommending against, probably that's too strong when you find a significant improvement. And
Yeah.
they know that some people do benefit from these effects. And yeah, I mean, it's kind of interesting why they went by this. Again, I think it all depends on like the composition of the panel at the end of the day, I feel.
Sure. And like I said, like, I'm not putting any judgment on individuals and their biases. I'm simply just stating the fact that, the argument that I think was happening all the way through from 2013 to 2022 now has been, we need to differentiate HA in terms of, elements, and the higher molecular weights seem to have a much more, stronger effect. And I think they're recognizing that in this updated guideline. Then they flipped also to the 2013 version of the interarticular corticosteroids. And again, at that time, there was an inconclusive recommendation. And again, they said that they weren't sure what the value was. And similarly, if you look, they have in the recent one, they have actually shifted again, right? They said, well, no, we think there's actually value now for short-term relief for patients with symptomatic KneeOA. So that's different. So that's also been a new change. The paper that I think that created a lot of challenge, and I suspect you're aware of this one, others maybe as well, was the paper by Timothy McEllennan in the JAMA 2017 that basically said, among patients with symptomatic KneeOA, 2 years of intra-articular triamcinolone compared with intra-articular saline resulted in significantly greater cartilage volume loss and no significant difference in knee pain. These findings do not support this treatment for patients with symptomatic KneeOA. Again, for those of you who aren't aware of this paper, this was using intra-articular corticosteroid injections given 4 times, I believe, right? 4 times.
Every 3 months.
Yeah, every 3 months for a period of 2 years. So 8 injections, and then doing MRI findings over that period of time. When you saw this particular finding, Ravi, what was your take on this particular paper? And more importantly, it really hasn't led to a massive shift in use, let's say, of corticosteroids. I do think, however, that this paper, raised awareness around, well, long-term repeated use of corticosteroid, but most common use of corticosteroid has often been sort of for that early acute inflammation. And I don't know too many folks who are using it, for years on end, although there may be some. And curious what your take is.
No, I mean, I think the major focus of this trial when they started was to see to see the structural changes when you start injecting steroid multiple times in a year. So that's why they designed it that way. And when they designed a structural outcome trial, they did not go and design clinical outcomes properly. So what I felt was like they were not collecting the clinical outcomes at the right time to see if steroids would be really effective. As we all know, steroids their effect is like pretty short-lived. And I mean, it depends. Some people may get 2 weeks of effect and some will be like 4 weeks or 6 weeks but then they were measuring like once in 3 months.
Yeah, it's interesting too, right? Like they themselves make the point, right? If you look at in their own paper, they made it very clear about this paper, which is, pain was not measured within the 4-week period after each injection, during which we know benefits are known to occur. So in fact, they said, they'd already acknowledged that there's a short-term benefit to using short-term, meaning within that first 4-week period, which I think you're acknowledging as well. So I think this paper really, like it was many ways the same as the earlier paper, except they'd use MRI. But the truth is they were all saying the same things for the most important part, which I think also has given confidence in the American Academy and other groups to say that there is certainly short-term benefit to this. Let me just switch in the last few minutes here to talk a little bit about PRP. So PRP, again, was inconclusive in 2013 due to low quality evidence. And even recently, in the most updated, they say, well, high molecular weight has a role, intra-articular corticosteroids for short term, but PRP continues to remain highly variable. And I go back to a paper we did not that long ago, and if we look at this, looking at all the different treatments, and just to orient everybody, this is a series of non-operative approaches, including some of the injectables. I'm focusing here on the PRP. This line here is the threshold for a minimal clinically important difference if we take the most conservative estimate, which is 0.5. So it's a pretty high threshold to beat. PRP does pretty well with respect to an average effect. If you look at this, right, it's pretty high average effect. But what do you notice? The 95% confidence interval is really, really wide. The truth can be a massive effect or absolutely no effect at all. And that has been, I think, the challenge right now that they have, is that while some purport, really impressive effects, there's so much variability right now that I don't think we have an answer. I wonder what your take is. You're certainly aware of evidence. Any other insights or thoughts about PRP?
I mean, I think PRP is kind of, as you said, I mean, there's not much of an effect when it's compared to intra-articular placebo or control. But most of the studies, at least 70 to 80% of the studies in this space, intra-articular PRP is being compared against intra-articular hyaluronic acid. And almost all of these trials were designed as non-inferiority trials. So that means they don't need to show superiority. So they can just kind of tag on to the lower end of the confidence interval of the hyaluronic acid effect, and they can say it's non-inferior. So the majority of the intra-articular PRP trials are of that design. So that's why, they are unable to really separate. And also, if we look at the intra-articular placebo trials, no, they don't have to have that many trials. And even whatever trials they have done, they're very small trials. I think that's why this confidence intervals is too wide.
Got it. So, I mean, this is kind of where we end up, right? I mean, I think people have kind of heard this. I wonder if we can, in the last 3 or 4 minutes or so, do folks have any questions? I'm gonna take us off of the screen share, and just anyone have any questions? If not, I mean, I know we're a little bit past our 30-minute time limit. I was hoping to keep this to 30 minutes. But if you have any questions, feel free to either unmute yourself, ask directly, or if you have, oh, here we go. Has anyone got experience with intra-articular injection? Anyone want to talk about that particular product? I don't know. I think it's pretty early.
Yeah, lorisibavir, I think you're right. It's very early, and yep. I mean, we participated in some of the trials, but yep, I do not have any clinical experience much of that. And also, especially in the US, we have issues with reimbursement. So yeah, we're still early with that data.
Hello.
Hi, Rob.
Yeah, Robert Luba. So
Hi.
I think it's there's an evolution in knowledge, and as you mentioned, now the high molecular weight hyaluronic acid is sort of the gold standard. And any tests that were done in the past or any studies using low molecular weight, you have to take them with a grain of salt, because that wasn't the optimal hyaluronic acid. So if you isolate and just use high molecular weight, then you get the true value of hyaluronic acid. And it's the same with the platelet-rich plasma. It's still, I mean, leukocyte rich, leukocyte poor. It's that's the problem with the studies. The different ways of procuring the platelet-rich plasma are different. There are many different systems out there, and some of the studies don't even tell you whether it was high molecular weight, or don't even tell you if it was platelet rich or platelet poor. So I think the challenge is to find out what, or to determine which subset of any particular group is the optimal group, and then compare the optimal treatments of the different groups to get the true value. And I think we've reached that with hyaluronic acid, but perhaps not with platelet-rich plasma. There's still some confusion with platelet-rich plasma.
I think you're right. I mean, I think it's quite accurate. I don't think we need more trials with HA. I mean, you can always say you can do more, but I think we have enough signal there to understand, the nature of that. With PRP, though, there's a big chunk of early experience with that. We're just trying to find indications, right? Explore indications. You know, if you know the PRP literature, it's been used in countless indications, and we're starting to see, you know, narrowing on lateral epicondylitis. We're starting to see narrowing on, you know, knee osteoarthritis, and we're seeing more focus on that area. What we need to do now is really understand the same way we did, you know, PRP as a you know, large class, tons of noise. And so we've got to
Yeah,
start
there's a lot of
thinking
heterogeneity there. So
right.
you're right. I mean, like the products are totally different, and we do not know exactly which product and what type of product they're using. So
Right.
yeah, there's a lot of heterogeneity there.
Yeah, right. But if you look at, you know, what we know, so let me ask you this, Ravi, like in terms of when we think about injectables, you know, is there so there's clearly a place for short-term use of corticosteroids. There's clearly a place from the evidence would suggest for higher molecular weight HA. Is there currently right now, based on your experience with the evidence for PRP, I mean, with the ORSI recommendation, which I know you were a lead in, what did ORSI say about PRP? I mean, the American Academy is very, you know, fairly ambiguous, basically saying they don't think there's much here, there's too much noise. What was ORSI's statement on PRP?
I think RC was also of similar kind of opinion. They felt like, okay, there's too much of heterogeneity, too much of noise, and we're not sure, like, I mean, even if there is some effect or whatever effect is coming from which product.
Yeah.
And yeah, I mean, like each, I mean, anybody can choose kind of their own product type. So it's not like there's a certain formulation which would work. So we're not sure about that. So they came out with a more in conclusion recommendation.
Understood. All right. Great. So this is Tom Bertoya. There's a trend now in combining HA with steroids, which with the combination therapies. So is there a comment on this practice, and is there evidence to guide frequency of injection? So I don't know if your guideline work compared, you know, looked at specifically the combination injections, Ravi, but you know, there are hyaluronic acid used in combination, you know, trying to get the, you know, purported benefits of the early acute effect of a corticosteroid with the potential longer term effect of an HA.
Yeah, I mean, like definitely we with the RC we did not look at that kind of combination, and also definitely the Australians also did not look at the combination. But in the clinical practice, I know, like, I mean, even in our clinics, sometimes depending on the patient, we do both. We do the combination.
Right, and I think Dr. Bertoya is getting to is the issue of, you know, repeated use of corticosteroid, for example. Would it be more like you'd use the combination therapy, but then subsequently just transition to, let's say, an HA? Would the evidence support that, or would the evidence support repeat corticosteroid? And that's a hard thing. To be truthful, you know, it's hard to know, Tom. I don't know the answer to that. My thinking is, if you take, you know, these trials at face value, that, you know, at 2 years, there's going to be a portion of patients who will on MRI have fibrillations that will otherwise be non-recognizable with respect to anything else. And certainly the plain x-rays wouldn't show any difference. And you're concerned that could be a reason. If you're going to give, you know, eight injections over 2 years, that would be what the evidence really suggests. There are others who might say, you know, I don't really necessarily think of that as a clinically important outcome tool as an MRI with fibrillations, and I would continue using it depending on, you know, sort of the pain and guide sort of treatment and guide sort of a response to patients. So I'm not sure if we answered that question, but anyways.
You know, the one thing that Robert Luba again, one thing that's food for thought. I mean, there's thought that the hyaluronic acid may have some chondroprotective capacity. It may actually protect the cartilage in the knee, and there's some studies which suggest that if you get the hyaluronic acid at a regular interval, say every 6 months, you might put off having knee replacements because of this chondroprotective capacity. You wonder if you use the hyaluronic acid in combination with corticosteroid, if in fact corticosteroid is thought to perhaps have some damaging effect on the articular cartilage, whether that effect, if indeed
dampened, is dampened, you mean? Yeah.
Is increased by the hyaluronic acid.
Yeah, I mean, the one, you know, there's a meta-analysis we did. I didn't present it here because it wasn't part of a guideline per se, but we looked at the combination therapies, about 8 randomized trials that have looked at combination therapy against, again, a host of controls, Ravi. So you would argue that there's all kinds of heterogeneity, but let's say, you know, it did exactly what you thought it would do. Combination therapy versus HA alone in that early period, you see that, they do very well quickly because you get the corticosteroid effect, but it does seem sustained, So, I mean, again, we didn't adjust, so we don't know why it seems sustained, but there definitely seemed to be that if you get ahead early, you can stay ahead. And maybe that's part of that psychology. I noted, Tom, that you would come on to video. Did you have any follow-up?
Yeah, you got the point that I was asking. Really, that study from 2017 that raised the question about repeated steroids, and certainly it's been long-standing sort of knowledge that repeated steroids can lead to accelerated joint damage. The problem is what is frequent and what is prolonged is what we don't know.
Right.
My practice has sort of been the knee that's got an effusion. When I'm going to do my HA injection, get some steroids added. The knee that comes in that's really dry just gets HA. And I'm not sure if that's right or wrong, but I tend not to add steroids for each and every injection as people go along sequentially. And I've some patients in my practice who've been getting HA for 7, 8, 9 years, and it certainly has prevented them from getting total knees.
No, and I think it's a very reasonable approach. I think countless, we've talked a lot about this topic, and I think most surgeons or injectors who think about this issue for patients think the same way. I noticed, Donald, you came off of mute. Did you want to say something?
One of the values of a presentation like this is to see the benefits of a variety of different treatments in your management of osteoarthritis of the knee. I'm retired now, but in my previous experience, one of the benefits of having a variety of treatment options is that in the times previously to the pandemic, when you had an opportunity to follow your patients more regularly, and so they were your patient. You didn't wait for someone to refer them to you 2 years down the road. I found that there are some patients who had a remarkable response to high molecular weight hyaluronic acid, and others who didn't. But I also had available the corticosteroid injections and could use those, and those who showed a distinct benefit, and the patient often would come back requesting it. So that now with your findings of some of the other data, with the data of other treatments, one of the benefits is that what I don't see is a lot of harm being caused by having PRP, high molecular weight, and corticosteroids together and so on. So it provides the orthopedic surgeon with a distinct benefit in options, and the surgeon should be careful not to be one or all one and none of the others.
No, and I think, well, again, thank you for that comment, Donald. That's excellent. Again, very sage advice to all of us. I mean, the reality is that you use as many, quote, tools in our toolkit as we can. We'd like as much as possible to understand where they may work, and use them, as we can. Evidence certainly helps guides us, but as you know, you're in front of the patient and you're making those patient-centered decisions every day. So thank you for that. Any other questions from folks? We make sure we don't want to have anything. We do have a good opportunity to have an expert in Ravi who's been so involved in the development of so much of this literature. So I want to make sure if you have anything you want to get asked, he would probably have the answers. I see that I think most people seem sufficiently satisfied or tired, one or the other. But either way, I'm going to take this opportunity, if I can, to thank you, Ravi, to thank all of you for attending. I think this is always great to have a small group of us discussing and chatting. And the more we talk about these guidelines and the more we talk about evidence, I think the more we align on things and the more we hear opinions that may not be ours, similar to ours, but sometimes they are, and we get confirmation when they aren't. It encourages us to think differently or to challenge it. So, and with all of those, I think have been met this evening. Ravi, thank you very much. And again, thank you to all of you who attended. Really appreciated your time, and we look forward to sharing this with you in more detail. This is recorded, and we'll make sure we get this out to everyone as soon as we possibly can. Have a great evening, everybody.
Thank you, Mo, and thank you everybody for attending. Thank you so much.
Take care.